Oh, all right. So, of course, I got cut off by a phone call. So, we're going to pick back up to where I don't even remember where we are. All right. We're going to go. Let me open my slide here. All right, I guess we're on page 867. Rotation sites for injection of insulin. All right, to touch on that. So, when people have to self inject or you're injecting people with insulin, then this is a good little diagram to show you that where you can um, do the insulin. And you want to rotate. You don't want to put it in the same place over and over and over. People like to do that when they're giving insulin to themselves because it stops hurting over time because they form a little callus there. And we don't really want you to put it in the callus because then you're not really getting your insulin. It doesn't really go into your system. So you need to rotate the sites. So you can see the recommended areas there and the areas that are possible. A lot of times we give it in the back of the arm or maybe even in the thigh. But of course the best place is a couple of inches away from the umbilicus all the way around to the flank area. Your next slide has a picture of an insulin pump, and that is on your next page. Insulin pumps can be an alternative to insulin therapy by daily injections is the insulin pump. These people, there's a couple different kinds of pumps actually, and there's some very new ones that you can even control with your phone. It's just all kinds of crazy things. But typically speaking, people will get their regular doses of insulin at a scheduled time through these. And if you need extra insulin by glucose monitor when you stick your finger, and if you need an extra dose, you can probe that in as well to your little monitor there, and it will give you the extra dose. So the insulin is in cartridges on the inside. So you just have to be careful. And I know a lot of diabetics who have insulin pumps that say, I'm going to go eat a big piece of cake today and then go set their insulin pump. And that's not really what it's for. Remember, we have to watch our diet. But I can control it by either getting boluses where I get the regular dosage at a particular time during the day that's set, or I can give myself another dose if I need it, a correction dose. Make sure you look at your clinical cues. Insulin pump will have to be disconnected for certain diagnostic tests, such as MRI. No metal can go in those. So it's important you think about those things if people are on insulin. Now, it talks about endocrine mimetics in here, but that was already covered in your farm chapter when you guys did the drugs for this chapter, so we won't have to go back over that again. Let's see here. Islet cell transplantation. That's kind of, you probably won't see that for a while. It says it's still in clinical trials, but remember your islet cells, your beta cells, are the ones that don't produce the insulin anymore. All right, so we can do transplantation there. Actually, we can't just yet. I think it still says it's in clinical trials. But remember, if I take a piece of anybody else's body and transplant it into my body, then my body wants to reject it. Just like with a liver transplant or a kidney transplant, whatever it may be. These are islet cells from somewhere else, so my body's going to want to get rid of it all the time. So you'd have to take immunosuppression drugs for the rest of your life so your body doesn't reject the cells that were put in to help with my insulin production. Nursing management is where at? I don't know because it skips around in here. But nursing management, you want to monitor the trend of the blood glucose. So if you are the nurse in a doctor's office or a nurse in the hospital and the doctors are sending your patient home, telling them to watch their blood sugar, then it's going to be up to you to teach them how to stick their finger. Remember that I hope you guys stuck your finger yet before, but you're going to clean it off with alcohol, let it dry, stick the finger, get a drop of blood, wipe that first drop off, and then use the second drop. So you teach them how to do that at home, and they need to keep a log of that so they can keep up with their doctor what their blood sugars are doing during the day. All right. And you're going to also look at that A1C every few months. You can't do it every month because it shows you a span of 3 months. So, if I had that original A1C and it was bad, they would put me on a diet and exercise or whatever they're going to do, maybe medication. And then a few months later, possibly around 6, they'll check it again. So your medicine has time to work. Monitor for hypoglycemia after insulin injections. You're going to have to teach your patient what hyperglycemia and hypoglycemia looks like. I also want you to pay very close attention to that safety alert in 869. It says when you go into your patient's room and you can't tell if it's hyperglycemia or hypoglycemia, then we're always going to treat it like it's hypo. All right. So if you don't have a blood sugar monitor handy or whatever it may be, you're always going to treat it. And most of the time you will have one handy. But if you're waiting for a lab result or whatever it is, you can't really tell because sometimes they mimic each other. If they're very out of it or whatever and you can't tell, you don't have a blood glucose reading, you're going to treat it like it's hypo. All right. So you would give sugar, or you'd give the glucagon, or you'd give the D50, whatever it may be, and that would raise the blood sugar up. And if it didn't work, of course, then you would know it was hyper. But it's going to be a little bit easier to get it down. I'd rather it be high and try to get it down than way too low and keep on going. So if they were, 30, and I gave them insulin, and it's going to drop it even more. So we're going to treat it like it's hyper, or excuse me, I was going to treat it like it's hypo if we don't know the difference when we walk in. We want to monitor for signs of ketoacidosis, which is your next slide. That's on page 869. Diabetic ketoacidosis is a serious condition caused by incomplete metabolism of fats resulting from an absence or insufficient supply of insulin. Remember, these are typically going to be your diabetic type 1, your juvenile diabetic people. When insulin is not present in adequate amounts to meet metabolic needs, the body breaks down protein and fat for energy. We don't really want to break down protein. That means we start kind of breaking down our muscle tissue. Our body can't really dispose of that as waste, so we have a buildup in there. So all the people who go on those keto diets are kind of doing the same thing, not to the extreme, but you don't really want to break down protein for energy. That's your muscle and tissue. So when that happens, this produces an abundance of byproducts, which are potent organic acids called ketones. We don't want those to build up. They can mess with everything. All of my organs, they can mess with my brain, everything. In an attempt to rid itself of the acidosis products by ketones, the body increases respiratory rate. We call that Kussmaul's respirations. And acetone in a ketone bodies is excreted in the urine, causing acetonuria and ketonuria. So I'm going to see acetone and ketones in the urine. Now, your side effects are going to be important for this. You're going to have a fruity odor to the breath, like juicy fruit. And really, it is quite sweet. And you're going to see those other things. People with really fast respirations, they might be quite confused. And, of course, you're going to be losing acetone and ketones in your urine. And that's going to be how you're going to know. The goals for treatments on the bottom of 870. The goals for treatment are to restore the normal pH of the blood and other body fluids, correct the fluid and electrolyte imbalance, and lower the blood glucose gradually. So these people are not going to get large injections. They're going to get an insulin drip where they can do a little insulin at a time. And that has to be adjusted per what the blood sugars are, and your doctor orders that. So he may say every 4 hours, get a finger stick, see what it is, and adjust the glucose. And you'll get a sheet that tells you how to adjust that glucose. And it'll say, well, if the blood sugar is higher, then you go up on insulin. If it's lower, you may go down. If it's the same, you may stay the same. Of course, you'll have orders for those. You also have a table on 870. It's 37.6. It's comparison of hypoglycemia and ketoacidosis. Really good to look at. Can give you some good information. Clinical cues is good too. If you expect DKA, which is diabetic ketoacidosis, immediately ensure that there is at least one patent IV access, because you're going to give some IV insulin. Treatment, of course, of ketoacidosis. Treatment, we talked about that. Prevention is try to watch your blood sugars and eat right. Okay, almost everybody I've ever taken care of in DKA was people who were non-compliant with their diet and their insulin. Patient teaching for people with diabetes, definitely foot care. We talked about how your feet, they get tingly, they lose feeling, and because of that, they can get wounds easily they don't know about. And so they have to make sure, and those wounds won't heal because of vascularity changes with diabetes. So they have to have very meticulous foot care, make sure that your feet are dry. We don't want any water in between the toes to stay there. You have a fantastic little patient teaching area on 872 for foot care. I want you to read it, please. All right? They have to look at their feet every day. They have to change their socks every day. They have to wash their feet in warm water, not hot, because that can crack the skin. Mild soap, because we don't want it to crack. It says, talks about cutting the nails, but most people have a podiatrist cut their nails. Break in new shoes gradually. Just read those things. There's plenty of them. All right, great patient teaching for everyone with diabetes. What to do on sick days. Sick days, I don't know, I thought was in here, but most of the time on sick days, you might have to have a little bit of extra insulin. Usually when we get sick, our insulin goes a little bit higher. So on sick days, you're going to have to watch it a little bit more closely. And if you're on insulin, adjust it. If you're not on insulin, just make sure you're really watching what you eat. I'm sure somewhere in this chapter it talks about sick days. I don't see it. Something I do want to check on, I want you to go back to, is on page 871. I don't want to skip this. I want to talk about rebound hyperglycemia, and this is called the Samogi effect. It says rebound hyperglycemia, also known as the Samogi effect, follows a period of hypoglycemia, often during sleep. So my blood sugar drops. And then when hypoglycemia occurs, the body secretes glucagon, which is sugar that your body secretes from the alpha cells in your pancreas, epinephrine, growth hormone, and cortisol to counteract the effects. And I wake up with a super high blood sugar. All right, so people usually give their patients and themselves, if they're diabetic, a small snack before bedtime to try to combat this. And then sometimes they have to really watch their insulin if they're on insulin the next morning. So usually, though, if they start increasing those doses of insulin, then it's going to make it worse, because at night you'll still be dropping. So I would definitely make sure the doctor knew that, and you're going to want to have that snack at bedtime. The dawn phenomenon is also another one. Is characterized by elevated blood glucose in the morning. The dawn phenomenon is caused by release of growth hormone, glucagon, and epinephrine during the night as part of the body's natural circadian rhythm. And remember, back in fundamentals and circadian rhythm, there's a certain time of day that your body does everything, and that's how it gets used to it. So in the dawn phenomenon, it's just your body's time to release that stuff, so the blood sugar is high in the morning. Different from rebound hyperglycemia, because rebound means that I got really, really low during the night, and my body tried to correct itself, so I'm high in the morning. So both of these, really watch that rebound hyperglycemia, though, because you don't want people really adjusting their insulin for that, because it's just going to make it worse. I'm looking to see where these happen to go with your slides, but they're not really following very well, are they? All right, your long-term problems on page 871, make sure that you're really looking at the damage to the large and small blood vessels, termed macrovascular and microvascular. If your blood sugar gets out of control, remember how we talked about the vascularity in the lower extremities? If you do not keep your blood sugar below 100 most of the time, it's going to start doing some damage to those vessels. And then I have a really big problem healing, because I have no nutrients and blood getting to the site. Really looking at your cardiovascular disease, because diabetes and cardiovascular disease are like this, hand in hand. And the key to cardiovascular disease, again, is keeping your diabetes under control, under 100. The alteration, it does say too, in the macrovascular system results in coronary artery disease, and that's where we get the coronary problems. And then it talks again about the diabetic neuropathy, which is the tingling, the numbness in the feet, and the retinopathy, which means I could lose some eyesight. Above that, it talks about hypoglycemia. Just go ahead and highlight too. It says 40 to 60 is considered hypoglycemia. That's a good rule of thumb. So I suppose this book's probably saying 60 to 90 might be normal blood sugar, but a lot of places say 70 to 100. I don't know what it says in this book. All right. We're going to slide 24, short-term complications. I don't really see where that is in your book to follow along. Oh, I did find your sick days, though, and they're way away from the slides. So we'll just keep going with the book until we get there. Page 873 shows a picture of a glucometer. You guys learned that back in med admin. They'll be different everywhere you go, but you'll get trained on them. Planning on the next page, under the planning, you've got finger sticks for blood glucose testing should be performed 30 minutes before breakfast. It says down below that if rapid-acting insulin is ordered, it should not be given until the food tray is in front of the patient because it happens quite fast. The blood sugar falls, all right? I still stand by what I say that most of the time you're going to get a short-acting, but definitely if it's rapid-acting, you want it there. All right. We're going to skip over to page 876. Below the assignment considerations, actually I want you to read the assignment considerations, okay, because that one's important. If you're going to give an unlicensed personnel this assignment, to remind that person at UAP to report any breaks in the skin or giving baths or anything so you can take care of it. Underneath that, I want you to highlight, though, when we're talking about implementation, underneath that assignments consideration, you see any type of stress can alter the control of the patient's diabetes. So, and that's a couple of reasons, because stress makes you forget to take care of yourself, right? And then stress also has a chemical release in your body. It causes a chemical reaction. It makes you, all your blood sugars to go out of whack. So you want to watch that. In areas of sickness and stress, this can happen. Now, in 877, under patient teaching, you have what to do on sick days. I want you to go over that. On 877 too, the first column, second paragraph, monitoring for signs of ketoacidosis is essential. Some of the earliest symptoms may be polyuria and that fruity breath. All right. Look for the beginning signs of dehydration with decreased skin turgor, sunken eyeballs, and dry mucous membranes. That will take you back to that ketoacidosis. I know I'm talking fast, so just pause when you need to. Make sure you're going over that what to do on sick days. Also, patient teaching below instructions for traveling. You always want to carry twice the medication or insulin just in case you have a breakdown or anything like that. Carry an emergency supply of fast-acting sugar in case your blood sugar starts to drop. You guys should probably, people should carry candy or glucose tablets. They're very sugary, so that gets their blood sugar up. And also carry some snacks that will keep your blood sugar raised, like crackers and stuff like that. Working with older adults with diabetes is the next section for patient teaching I want you to look at. Assess the hearing and vision because I want to know if my diabetes is making it worse, so I need a baseline there. Set a time for a teaching session, and sometimes if it's an older person, make sure they have somebody with them that can help them when they get home, that can remember the stuff. Make sure they're comfortable because it's going to be a pretty long session. Actually, this says keep it short, no more than 15 or 20 minutes. But, for some people, that is kind of a long session to sit. But you definitely need that time. Go slowly and ask for feedback. Allow for patient to write things down. Repeat key concepts frequently so they understand how important it is. Give them bold type printed material. Give printed material to their family. Printed material should be on the 5th to 10th grade reading level for those people who didn't go all the way through school. So pretty much everything 877 patient teaching all the way through the patient teaching on 878 is going to be very important. Okay. For hypoglycemia, look under the signs and symptoms there. Of course, that's very, very important. Hypoglycemia includes rapid heartbeat, tremors, weakness, anxiety, nervousness, and hunger. Sometimes can occur rather suddenly within about 4 hours after a meal is eaten. Some physiological symptoms may be mistaken for indications such as psychiatric illness. This could be irritability, personality change, temper tantrums, and other different manifestations. So if you walk in, especially if someone's elderly, for one, if they're very, very lethargic and I know they're diabetic, I'm going to get a blood sugar. All right. If anything looks weird, when you get to the hospital setting, you'll see. If anything starts to look weird with their neurological function, the first things we do is get a blood sugar and a set of vital signs. It's just how it goes, just to make sure that everything is kosher. All right. And that is the end of the chapter.